Our final speaker before the wrap-up is, like Dr. Wodak, at the coalface of human rights concerns. Dr. Charlie Corke is a senior specialist in the intensive care unit at Geelong Hospital. He's the author of a book, Saving Lives, and some of you might remember him from a recent documentary called In the End. Dr. Corke is going to give a paper on avoiding dysthanasia, not striving for euthanasia. So I'd like you to join me in welcoming Dr. Corke.
Well, thank you very much. I'm very honoured to be asked to come and talk here today, and somewhat humbled to follow on from such amazing speakers that you've had earlier on. It's probably logical to finish up with death. And really, earlier on, the human rights that we've talked about are protecting the rights of vulnerable others. But really what I'm going to talk about here is about our rights, because I can be very confident that everybody in the room here is going to die. And so it's about us. So pay attention. Euthanasia is back. We've had a dabble with euthanasia in the Northern Territory. We've had all the reactions that one would predict that would happen with that. And now as it's come back again, the issues are the same, about protection of the individual rights and autonomy, about choice, about compassion, and about death with dignity, against the sanctity of life, the fears of a slippery slope, and the failure to protect the vulnerable. And like you, I've heard lots of debates about this, and they're all the same. Where it's been implemented, it needs to be a voluntary, well-considered and persistent request. The patient's suffering should be unbearable and hopeless, and we'll come back to that. The patient should be informed about their situation. There should be no reasonable alternatives. The patient mustn't be depressed, and another physician must be consulted. So the process is there for it. But the difficulty for doctors implementing this are that there's significant problems of evaluating whether somebody else's suffering is unbearable and hopeless. It's a very subjective thing. And that the request is voluntary and well considered. How do I know? All the inputs that other people have in their decision making is very difficult and well considered. What do I think is well considered, and what do you think is well considered? So from the Dutch experience, a large proportion of doctors express the view that this is difficult. And the problem as well is that where we're looking at euthanasia, we're talking about taking control of our dying. But in fact, what we end up doing is having our dying still controlled by a load of other people who have to judge whether the criteria that we are suggesting for ourselves are actually true. And that's exactly the opposite of what those who wish for euthanasia want. They don't want to go and see a lot of doctors and have a lot of other people check out whether you're right. The other problem is that where we do have euthanasia legislation, not many people use it. A lot of people die, very few people die as a result of active euthanasia, even where the legislation's in place. But perhaps more importantly, if we look in Oregon at what are the things that people are saying are their reasons for requesting assisted suicide. And I think if we look here, if I can make this work, loss of autonomy, very high. Well, I don't think any jurisdiction is going to have, if you feel you're going to lose autonomy, you can apply for euthanasia. You know, this isn't anything here about, this thing about terrible suffering isn't here. Inability to do enjoyable activities. So sorry, I can't do enjoyable activities, so I want euthanasia. Please, politicians, agree to it. They're not going to. Loss of dignity, loss of control of body function, being a burden. So the reasons that people are listing in Oregon for reasons why they want euthanasia are not about uncontrollable suffering. They're about choice. So when we look at this, I suggest that although personally I'm very happy if there's legislation, I may like to use it in the future, personally, as far as a practical use of it in a medical sense, I'm not sure that it actually addresses the issues for most of us. And I'd like to talk about dysthanasia, which I think is something that I recognise all the time. And I'd like to reduce the size of the text for euthanasia there, just to make it clear that we're not going to talk about it anymore. So the Australian life expectancy is 81.4 years. Obviously a bit less for men. Which means that when you get to 80, it's very likely that between 80 and 90 you're going to die. And if you get up towards 90, you've gone above the average. So how we finish up our lives is becoming a major issue for us as a society. And I believe an issue that's not recognised adequately. Because we're not actually, what we're doing for most of us, instead of actually actively coming to the end of our lives and taking action to make that happen, what we're actually doing is extending the dying process with a ferocity that's amazing. As families, as individuals, we are using healthcare to drag out the end of life as long as we possibly can in many, many situations. So this was an interesting poster, which I think is the most amazing poster in terms of the number of places that it got put up in every intensive care unit across the country and internationally. It just said what we all saw, what was happening. Never, 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 never give up. Perhaps the one of the child kissing the pig in the swine flu got up a bit more, actually. Within our poetry, Dylan Thomas, that if we think about poems about death, I'd say that this is the poem that we all recognise. Do not go gentle into that good night. Old age should burn and rave at close of day. Rage, rage against the dying of the light. Do not go gentle into that good night. He's writing about his aged blind father who's failing and coming towards death. And instead of being able to embrace his father and help him, give him permission to go, Dylan Thomas is telling him to pull himself together, to get up and go back to being the vibrant sort of person that he was earlier in his life and that he admired. And that's perhaps the poem, and poetry I think does tell us about how we react as a society, and that's what we do. So for me, life support and intensive medical treatment can certainly be saving life and be magic, and that's why I do it. But also it can be prolonging death, making it more complicated, more drawn out and more unpleasant through the use of medical technology. At all costs, doing everything, never let go, and these are things that I hear from families all the time. In fact, amazingly, we hear from families saying, I don't think she'd want it at all, but we want you to do it. So hope perhaps is one of the worst evils because it prolongs the torments of man, as Friedrich Nietzsche said. An unrealistic hope allows us at the end of life to do some terrible things to people. Also within our culture, cure is such a good thing, and acceptance and care is so bad. So cure involves fighting, trying, battling, being brave, not giving in, doing everything, caring, loving. Loving. The way you love people is to stick them on all the machines in our culture and not allowing it to stop. Whereas acceptance involves giving up, not trying, being weak, doing nothing, not caring, not loving, not intervening, passing by on the other side, being impotent. It's very difficult. Our culture doesn't like it. Now, when there was no medicine, when there was no life support, all of this was fine. You died because medicine was hopeless. But nowadays, we can drag it out. So I think it's interesting as well that the word for prolonging death and making it more complicated, more drawn out, more unpleasant, I mean, obviously our words developed ages ago. And so for dysthanasia, it's not really in the culture. You probably haven't heard it before. And which isn't a surprise, because when I look in the Oxford Dictionary, there is no word. It's not there. When I look on Google, I do find it. It's the official page of dysthanasia, and it's a Finnish heavy rock metal band specialising in near-classical dark wave, experimental funeral dark wave metal. I'd suggest that this use of dysthanasia isn't helpful to us, but the word is there, and we need to recognise it. And so I did this study looking at what actually happens in choosing life support for suddenly severely ill elderly relatives. Because what I see is that we gave this hypothetical case to a number of elderly people, and 83% of them said they wouldn't want intensive treatment under the circumstances, and it's pretty horrible. I'm amazed that a few of them did. Of their surrogates who were interested in this study were all girls, and there's literature to say that having a girl as your surrogate's a good thing because they're more compassionate in this situation. But all the surrogates, when we said, actually, your elderly relative is now in the emergency department, if we don't put a tube in now, they're going to die, and we just, what do you want to do? They said, yeah, we all want you to do it, and we all want you to put them on life support. And then we said, well, that seems a bit odd. So we asked them, and they said this is why they did it. The need for time to get family together, the need to reach a family consensus, the need to be more certain of prognosis, and they weren't ready. Of course you're not ready. It never happens at the time you're expecting it to happen. And chance was raised by all the surrogates, but chance was never mentioned by the patient. The chance of getting better, they were talking about the burden and how bad that they didn't want it. So it's interesting that we do this, and I suggest that it's this area of how we overdo medical treatment is much more interesting to me than euthanasia. And it's fascinating to me that we have wonderful legislation in Victoria, in the Medical Treatment Act of 1988, which is has been amazingly unused, amazingly unimplemented over nearly 15 years now. It was interesting, it was a Victorian Historical Act when I was looking for it. We use this now, but it's not widely used. And more importantly, the second part of it, in a refusal of treatment certificates, these are very powerful and very good part of the Victorian legislation, in that it's illegal for me to treat a patient if they filled out one of these. Most of my colleagues have never seen one. They are used so infrequently, it's amazing. So people aren't engaged in the idea that using the Medical Treatment Act, thinking about their line in the sand and how far they want to go, it is used to some extent amongst the medical profession and their families, but very infrequently used by other people. As well, a lot of lawyers are encouraging people nowadays to appoint a medical power of attorney. But the problem there is, I think, that they don't really understand what the agent is going to do, and they think it might be a bit like a financial power of attorney where you actually have power. And for a medical power of attorney, you need to earn the power. So the agent needs to negotiate with a neurosurgeon. It's not an easy thing to do. So they need to represent the patient's best interest, not their own interests. They need to actively seek information and actually have a dialogue, so it's a shared decision-making model. They need to recognise uncertainty and still be able to make active decisions. They need to deal with the rest of the family. They need to be someone who's used to making difficult decisions, who doesn't shy away from an awkward situation. And it's awful when families when a person appoints a very feeble agent who can't make decisions and then has years of guilt after they've done it. Not driven by emotion, a good negotiator, unfazed by bullying, that's the neurosurgeon again. To be able to assess complex data in an area where they lack expertise. That's actually quite a skill, isn't it? To go into an area that you know nothing about, and I mean, as lawyers, you're probably quite good at that. And then to adjust to circumstances, and actually lawyers make very good agents. So in conclusion, I think that prolonging death is now common, very, very common. And the penalty for letting death happen just beforehand. We had a very unfortunate case where a nurse discontinued life support from a patient where we'd otherwise stopped treating him. I wasn't mercifully involved with the case at all, but I had to deal with it as the director of the unit. And in this situation, this person who was clearly dying had the life support taken off by the nurse due to a misunderstanding before the supposed time that his natural death was going to occur, and we had the police round, and this was described as homicide. If he dies 1 minute, as the policeman said to us, as he was locking down the computers and doing all the other things, he said if he dies 1 minute before his time of dying, that's homicide. Of course, if you die 3 weeks after your time of death because it's been prolonged, that's no crime at all. So we're very, very sensitive about not letting death happen any earlier than it otherwise should be, but prolonging death is not a crime. It's extraordinarily common. We have good legislation that can actually assist patients and avoid an undesired prolongation of death, but we don't use it. It's been in existence for a long time, and it's only now becoming widely used, advocated, and at all effective. And I think there's a great way to go. And I would advocate to you, as lawyers, to use the legislation. I don't mind talking about other things, but it would be a shame if we were to put all of our eggs into the euthanasia basket, spend ages and ages arguing about it, when we actually have very good legislation that we could use sensibly and avoid a lot more people, benefit a lot more people than fighting over legislation that may be very difficult to actually implement in a useful way. We've started advertising for this. Planning makes your future care easier for your family, and that's one of the things we find quite useful in that context. This is the little book, Saving Life or Prolonging Death, that has a lot of the details about the issues in from a medical perspective. And I think if you are advocating to your clients that they do take use the Medical Treatment Act and appoint an agent, and I'd be hoping that you were, this may give you some of the understanding and may give your client some of the understanding about what it's all about. Because this isn't actually very much out there about the bad side of technology at the end of life. And just finally, the other thing is not just, also the doctors need to understand, and we looked at how doctors talk to patients who have very poor outcomes. So it's like the lose-lose choice. If you don't get treated, you die. If you do get treated, you die, but it's going to be a bit longer. And when we're discussing that with patients, they explain the medical facts reasonably well, but never talked about, or very rarely talked about, fears, values, and functional status of patients. And that's very important, because without doing that, you can't understand anything about the person that you're trying to advise and talk to. But none of this thing about patient-centred care is actually in the training of junior doctors, and we're now moving to include it in the training of junior doctors to try to help patients at the end of their lives to express their thoughts about being maintained on life support before it becomes something that's happened. And obviously, once someone's on life support, it's very difficult to ask them what they want. Thank you very much.
Now we have about 10 minutes for questions, so once again you'll need to fire away fairly quickly. Yes, at the back there?
Experienced recently two grandparents who passed away, and we had nurses, palliative care nurses. And I found they were in a very precarious legal position because they had this fine balancing act of providing pain relief, but no one could really say to them, can you increase the pain relief, because they're in enormous pain. Person can't say they're in pain. And there was this kind of constant tension between what we all knew was going on and them having obviously concerned about doing the wrong thing in the law as well. So what you've been discussing today, I'm just wondering how does that, or how can that be resolved under current legislation or in the future?
I think if the instructions that the nurses are given are clear enough that their goal is to control pain and that they have a dose range that's large enough, then they should have no difficulties. I think that's perhaps a procedural thing more than a procedural perception of exposure rather than a reality.
Right, but we have to be very careful as to what we said to them. So I have to keep my mouth shut about things like, if I knew what my grandfather said to me earlier.
What had he said?
Can you, I don't want to live anymore.
Yeah.
Days before he was unconscious. And so I wanted to say to them,
Well, you're entitled as a family member to say, I think he looks uncomfortable, and I think you can say that quite a lot.
but I'm just saying, I think that that's an unfortunate situation for everybody to be in. Because,
No. I mean, I agree with you. I mean, this end point where people are taking time to die is a lot of people find very frustrating and can't understand it. I'm with you there.